Swayam Prabha. Digital India. Educated India.
So the topic we discuss now is the acute renal failure or ARF. We will discuss it more from the pathological perspective, and the clinical perspective obviously will be discussed with the nephrologist and in a more of a seminar format. But this acute renal failure, we will go step by step to see that what happens inside the kidney which causes acute renal failure. Now, what is acute renal failure? So, most important component that you must understand the definition of acute renal failure is the inability of the kidney to maintain homeostasis, leading to a buildup of nitrogenous wastes. So, obviously, there are biochemical parameters which we can see in the patient serum, with which we have an indication that kidney is not functioning. There may be different to renal insufficiency where kidney function is deranged, but can still support life. So, there may be partial failure which is still have biochemical parameters or clinical parameters not much deranged, but still there may be abnormality in the renal function. And the exact biochemical clinical definition is not clear that way. So, there are a lot of studies and a lot of definition, but main thing is that when the kidney functions is not tenable or not doing properly and leading to certain biochemical and clinical changes, and also sometimes at subclinical level it can have a renal failure. If it is a very acute one, that is the duration is short in terms of days and week, so then we will call it acute renal failure. Now, it occur over hours and days. The laboratory definition is much more clear. What we can diagnose pathologically is increase in the baseline creatinine of more than 50%. So, say for example, a person's baseline creatinine is 1.2 milligram percent, and then within 2 days if it becomes say 2.4 milligram percent, definitely that is an acute renal failure. The decrease in creatinine clearance more than 50%, and that is related to decrease in the glomerular filtration rate, deterioration of the renal functions which requires the dialysis. So, these are the different laboratory definition of the acute renal failure. Now, clinically we can look it in a very different way. The patient may come to the OPD without any urine formation. So, there is no urine output which is even the less than 100 ml per 24 hours. So, we clinically tell this is an anuria. Then it can have less than 500 ml, and some people say that is less than 400 ml of urine output, that is in a per day, or less than 20 milliliter of urine per hour, then we call it oliguria. And then sometimes in the recovery stage of acute tubular injury, the person can have much more urine formation because tubular absorption is defective. So, in that case patient may present with a polyuria, there is more urine formation, there is more than 2.5 liter per 24 hours. Now, the cause of acute renal failure may be usually classically classified in under 3 heading. One is prerenal, where say for example, the blood supply of the kidney is very low, then obviously the filtration volume will be low and that will cause the renal failure. We will be more focusing on the intrinsic cause, that is the renal cause, which is the structural cause, and we will be talking about it. And then it may be post renal also, where there will be obstruction in the ureter or the lower urinary tract, which can lead to acute renal failure. Now, this will be discussed by the nephrologist, but just to mention, so acute renal failure, obviously when we try to work up, we try to see whether it is a prerenal, it is a renal or intrinsic or post renal. If it is intrinsic, we have to see whether it is a tubular interstitial problem or it is a glomerular problem, glomerular disease. And if it is a glomerular disease, we can try to further classify it as a primary and secondary glomerular disease, which we have already discussed in our classes of glomerulonephritis. Now, this is the same thing I think we are repeating again. Prerenal, I have told you, inadequate perfusion, and it can happen due to the severe injury or trauma, then hemorrhage, dehydration and all. And then renal cause, this is acute renal failure. Despite the perfusion and excretion, those functions are may be fine, but then you have a renal problem, renal disease which is causing acute renal failure. We will further elaborate on that. And post renal, obviously lower urinary tract is the one where you have to check it. Now, this table gives you more clear view. So, here we have important prerenal, renal and post renal cause. So, in prerenal, absolute hypovolemia and relative hypovolemia and reduced cardiac output and renovascular occlusion. So, these may the main cause of the prerenal acute renal failure. Renal, it may be glomerular, tubular, interstitial or vascular. These are the 4 compartments of the kidney may get affected. And post renal, obviously anatomically it may be pelvic ischemic region obstruction, ureteric, the VUJ or the bladder neck obstruction and bladder neck urethral obstruction. So basically these are the main cause of this acute renal failure. Now, prerenal, I think just to summarize, decreased renal perfusion without any cellular injury in the kidney. 70% of the community acquired cases, it can occur in several situations. So, we may not go into the detail, and in the seminar maybe you can listen more about it. Now, we will focus on these acute ARF due to renal cause. So, acute tubular necrosis is one of the very important cause of acute renal failure, and it may be mainly 3 cause, maybe either ischemic, toxic, or there may be other intrinsic tubular factor which can lead to acute tubular necrosis. Acute interstitial necrosis or interstitial inflammation and edema, that is acute interstitial injury, and then glomerulonephritis, already we have discussed earlier. Now, acute tubular necrosis, I think in this talk we will elaborate, because usually in the glomerulonephritis and interstitial nephritis, this component we have not discussed in details. So, it is the commonest cause of renal failure, and there is acute diminution or loss of renal function, and usually it is results from destruction or dysfunction of the tubular epithelial cells. Now, ischemia that can cause acute tubular necrosis, there may be different causes of ischemia, say vascular disease like polyarteritis nodosa, malignant hypertension, hemolytic uremic syndrome, or there is maybe some decrease in effective circulating blood volume inside the kidney. And direct toxic injury to the tubules, that can happen secondary to the drugs. There are several tubulotoxic drugs, radio contrast dyes, heavy metals, myoglobin, hemoglobin and radiation. Now, you can have mismatched blood transfusion, then also it can cause tubular injury. Now, acute tubular nephritis, it may be due to hypersensitivity reaction to the drug, and urinary tract obstruction also can occur in, I told you, the BPH, tumors and blood clot and other causes. Now, pathogenesis of acute tubular injury. In case of ischemia, there is structural and functional alteration in the epithelial cells. So, what happens if there is a ischemia to any cell? It follows the same principle of general pathology. So, initially there will be swelling of the cell, then there will be loss of brass border, particularly proximal tubular epithelial cells, and followed by blebbing of these submembranous region, loss of polarity, cell detachment, necrosis and apoptosis. So, this is leading to these loss of these cells. But in these, if you see the injury, different grades of injury can cause the reversibility and irreversibility of the cell damage. And while in the ischemia, there is also depletion of this ATP, and depletion of the ATP cause accumulation of the intracellular calcium, then activation of the proteases, particularly calpain and phospholipases, then that causes cytoskeletal disruption and damage to the membrane. So, in this area I have showed you the structural changes, and in this area, in these few lines I am mentioning the molecular mechanism which causes the structural changes. And then finally, all this leads to generation of the reactive oxygen species and activation of caspases, which causes apoptosis as well as necrosis of these tubular epithelial cells. So, this is the pathogenesis of tubular injury secondary to ischemia. Now, this diagram gives you a more interconnected mechanism what happens in ischemia. In case of ischemia, obviously there is endothelial dysfunction, there will be more vasoconstriction, renin-angiotensin system become more activated, resulting in increase in endothelin, decrease in nitric oxide and increase in prostaglandin I2. So, and then also ischemia causes the tubular cell injury, and the tubular cell injury again it in further there is decrease in the oxygen perfusion to the outer medulla, which gives rise to more vasoconstriction. In the tubular injury also we can look into the reversible phase and irreversible phase. In the reversible phase you have got the mild changes like loss of polarity, detachment of the some cells, and in case of loss of polarity you sometimes get tubular dysfunction because there is increase in sodium delivery in the distal tubules, because normal tubular reabsorption of water and electrolyte gets disturbed, and that causes increased tubuloglomerular feedback, and that actually cause reduced glomerular filtration rate. Whereas, if there is detachment of the tubular epithelial cells is more prominent, that is more cells get detached, then the reversibility actually decreases. It from reversible phase it goes to irreversible phase. In irreversible acute tubular necrosis, most of the cells undergoes necrosis and apoptosis, and this actually set in the lumen and they form obstruction by forming the cellular cast, and that causes increase in intratubular pressure, and finally that causes reduction in the glomerular filtration rate. And similarly, there may be a tubular back leak or tubular backflow, and all this leads to oliguria and sometimes anuria. So, this is the very clear or more or less clear picture of what happens in ischemic acute tubular necrosis. Now, so the key event in acute tubular necrosis is the tubular injury and also disturbance in the blood flow. The tubular injury is sensitive due to the charge selective nature of the tubular epithelial cells, ability to concentrate substance in the tubule, and also sensitive to ischemia. So, which I have explained in that diagram. And the disturbance in the blood flow leads to ischemic disease. It causes the reduced in glomerular filtration rate, damage to the tubular epithelial cells in the medulla. Now, ATN obviously is divided into 3 phases so far as the pathobiology is concerned. The first phase is initiation phase, that usually within 36 hours of the initiation of these factors which causes the tubular injury, and this insulting event with subsequent slight oliguria and beginning of azotemia. So, the changes are quite mild in the initiation phase. Then comes the maintenance phase, where there is a sustained decrease in the output of the urine, that may be 40 to 400 ml per day, and their electrolyte imbalance because tubular dysfunction has started, and it is associated with development of edema. And in this situation the patient can be managed by the treatment of the fluid control and electrolyte control. And then finally, if the injury is no more progressive, then the recovery occurs, and in the recovery phase there is steady increase in the urine output, subsequent polyuria as I explained initially, an increase in susceptibility to infection, and also hypokalemia due to excessive diuresis. Because in the recovery phase also the full tubular function is still yet to be recovered. So, there is a lot of functional disturbances leading to sometimes less water absorption and also abnormal electrolyte reabsorption. If the patient survives the cause of acute tubular necrosis, they usually regain normal renal function within few weeks. Now, the structurally what I have already told you, now this the schematic diagram shows you that different parts of the tubule has got different kind of metabolic activity and different kind of absorption and secretion activity, and that is why their oxygen requirement is also very variable. Like proximal tubular epithelial cells are most metabolically active cells, and that is why they are very vulnerable to ischemia. So, if we compare the different segments of the proximal tubule, also their susceptibility to injury is also very variable. Similarly, for a toxin, the toxins also sometimes injure particular segment of the tubule much more in comparison to the other segment of the tubule. That is why you have to understand that in ischemic type of injury and toxic type of injury, the segment of the tubules which gets involved are different, and sometimes there are certain features. If we see that there is more injury to this the proximal convoluted tubule with widespread with the loop of Henle, and then it is more severe kind of injury may indicate a toxic injury. Whereas, if we get the skip zone injury, that is some part of these proximal tubules and some part of this loop of Henle's are more affected than the other parts, then we can think of the type of injury may be more of a ischemic injury. Now, this is the typical photomicrograph of the kidney biopsy, which is showing you acute tubular necrosis. If you see these tubules, hardly you see the normal tubular epithelial cells, and there is only few flattened epithelial cells with hyperchromatic nuclei are seen, and these are these regenerating tubular epithelial cells. Most of the tubular epithelial cells are getting shed, and here you can see that the shedding tubular epithelial cells, and you can see them in the lumen, and here you can see some of the cast. In the cast also these epithelial cells are getting embedded. So this is the typical picture of the acute tubular necrosis. Thank you.